Hi everyone. My name is Nick Flattery. I'm the Senior Program Manager for Colorado Heart Healthy Solutions. And we're happy to kind of present Dr. Mori Krantz, who does many things, but he also works on our program, and he's the PI, correct, on the Colorado Heart Healthy Solutions program. As part of the program, one of our main goals is to get the most current information out there. And so this is really that, I guess, vehicle to be able to do that. And so without further ado, I'm going to hand it over to Mori. Take it away, Mori.
Thanks, Nick. I appreciate it. Well, welcome everybody, and welcome to spring. I think Nick's brought up a good point. This is really an interesting time because right now we have a sort of new blood pressure and a new lipid guideline that both come out almost simultaneously. So there's going to be a lot of changes afoot, and certainly for community health workers, case managers, nurses, and family medicine docs, there's some confusion and questions that may come up. So I'm hoping that this update will be useful to everybody, and certainly at the end we'll be happy to field questions and make it very interactive. So just to begin, the learning objectives today will be to review the ACC-AHA non-pharmacologic guidelines. I think we oftentimes forget that it's not just pills, but then also talk about the pills that we do use for treating blood pressure and review white coat as well as masked hypertension. And we'll look at the 2017 American College of Clinical Endocrinology lipid management targets and risk categories, which is kind of cool because they're a little bit more aggressive potentially in terms of treating LDL, as we'll discuss. One important principle to bring up to everybody is that we really want to contrast the treat to target versus the population-based approach to lipid management. And what that really means is, in a nutshell, do we have number targets that we want to go after for cholesterol, or do we just want to identify those patients or people in our community that would benefit from treatment irrespective of the cholesterol level? We will also focus on very high LDL cholesterol and some of the newer drugs. And as I mentioned to earlier, we're going to focus on a case-based format. So I'm not sure exactly if we have an audience response system. Probably not, but certainly to the extent that we can kind of get you guys involved, that would be great. There may actually be a chat function that you could use. Nick, are you familiar with that?
Yeah, there is a chat function. Also, I have unmuted people. We have about right around 10 people, so I think it should be a manageable crowd too. So when Mori asks a question, you can shout it out or put it in the chat.
Yeah, that'd be great. And again, there's no right or wrong answer. The idea is just to kind of keep ourselves engaged because you're more likely to gain from the lecture that way. So we'll start with the 2013 AHA-ACC guideline on lifestyle management, which was written by Bob Eckel here at the University of Colorado. He's an endocrinologist and has been very active in promoting not just pharmacologic but non-pharmacologic therapy. And I think the take-home message is, in terms of lifestyle, is that there's a real emphasis on dietary patterns that involve healthy foods, fruits, vegetables, olive oil, healthy fats, and the DASH diet and the Mediterranean diet are good examples of that. The recommendation is that fat intake be limited to about a third, and avoiding the saturated fats that you may see in red meats and trans fats that you may see in processed foods. Along those lines, there's a strong recommendation to cut out the processed or pre-prepared foods, so different types of lunch meats, et cetera, low sodium, and then emphasizing that this isn't just a change that you do for a week or two, that you want to try to incorporate these changes for a lifetime. In addition, physical activity is important for moderating lipids and blood pressure, and the recommendation currently is 3 to 4 sessions a week, lasting on average 40 minutes per session. And I think that's attainable. It can be challenging depending on your work schedule, but when possible, have it be moderate to vigorous intensity to really gain the maximum benefits in terms of blood pressure and lipid control, which we will show you what those numbers look like in just a moment. So this is kind of a goofy slide and really talking about the evolving risk of diabetes, dyslipidemia, and hypertension. And the concept really is that in our primordial state, when we were really hunterers and gatherers, we had very low blood pressure, lipids, and diabetes essentially did not exist, perhaps, maybe type 1. But as we progress to become more of an agrarian or agriculturally based society, and that we have more downtime where we're actually becoming more sedentary, you can see progressive increases in your blood pressure, in your LDL cholesterol, and even elevations in hemoglobin A1C to suggest the development of fulminant diabetes, and then ultimately, of course, heart disease. So we'll start with a case. This is a case of a 55-year-old man who wants to start the DASH diet. He's had high blood pressure for 5 years. He does take an ACE inhibitor, lisinopril, 40 milligrams a day. He's currently overweight and is not eating too healthy. His blood pressure is fairly elevated, 150 over 91, and we can talk about the stages of hypertension now. And he wants advice in terms of what is the potential maximum reduction in systolic blood pressure he could gain from adopting the DASH diet. So, and any thoughts? The choices are 4 millimeters of mercury, 6, and then 11. Any thoughts in terms of what the DASH diet could do for someone who's fairly hypertensive?
Any guesses out there?
All right, well, we'll just go ahead and move forward. Let's see if I can move this ahead. The actual benefit could be as high as 11, which is as good as some of your more potent blood pressure medicines. And so if you look at the proven non-pharmacologic interventions, but you can see that the healthy diet is bolded on the second row, with the DASH diet leading to as much as an 11 millimeter reduction in people that have baseline hypertension. You'll notice that if you're normotensive and you do it, you're only going to gain 3 millimeters of mercury, meaning that there's an asymptote effect. So if you already have a perfectly normal blood pressure and you adopt the DASH diet, you're not going to get the same benefits that you may if you were hypertensive. So there's more bang for your buck, the greater the risk. And so the old adage that we always apply for any type of risk factor modification is greater risk, greater the treatment benefit of an intervention, be it a medicine or a lifestyle. You also see that lowering sodium, reducing weight, and increasing dietary potassium can also be quite beneficial as well. In terms of physical activity, clearly there's aerobic, dynamic resistance, and isometric, and probably the best one in terms of lowering blood pressure would be the aerobic, but clearly you can see nearly the same reductions with dynamic resistance and with isometric exercise. So sort of the message is that there's an agnostic approach. Any exercise is recommended, and we really don't feel like it's got to be prescribed very clearly as to what type it is. Let's toggle now and look at the ACC guideline for treating blood cholesterol. And this was the one that came out in 2013, again, looking at sort of a new approach, if you will, that was potentially more simplified for treating adults with high cholesterol. And basically, in terms of the approach, this is what we had referred to earlier in the introduction as a population-based approach, meaning that there are 4 statin benefit groups, or people that are going to derive benefit from treatment. And the reason this is attractive is you can sort of just look at someone's profile and say, hey, you would probably benefit from treatment. And for those of you who are community health workers on the call that are using our Oscar system, it does develop a risk module for you and gives you your 10-year cardiovascular disease risk. So the first one's easy, secondary prevention. That means you've either had a heart attack, an acute limb ischemia event, or you've had a stroke. And in those patients, you're going to recommend very high-intensity statin treatment, irrespective of the cholesterol. The second group are diabetics that are in the middle age range that have an LDL cholesterol spanning as low as 70 and as high as 189. The third group are the people that we have genetic high cholesterol. Those are people with an LDL greater than 190, and these people, again, are called familial hypercholesterolemia. The final category that's probably a little trickier because you need a calculator is primary prevention, people that haven't had a heart disease event, that don't have diabetes, that don't have a genetic cholesterol problem, but when you calculate their 10-year risk, it's greater than 7.5%. And those folks benefit as well from statins. And in that group, rather than the high intensity you would do for secondary prevention, you would use moderate intensity statin. Remember, a lot of people think that this is just an automatic thing, that the minute you have a 7.6% risk, you absolutely must take a statin. And, you know, to be honest, this should always entail a clinician-patient discussion because there are other alternatives and you can potentially wait and modify lifestyle first. So it's not a categorical recommendation. So we mentioned intensity of statin, and I'll direct your view to the left panel, where we talk about high-intensity statin that can drop your LDL by greater than half, and those include atorvastatin, 80 milligrams, and rosuvastatin, either 20 or 40 milligrams, which are our most potent statin. And then you can see moderate intensity in the middle column and the low-intensity approaches that are listed for you there on the right column. So let's change gears for just a moment, and I want to talk about new reasonable LDL goals from the American Association of Clinical Endocrinologists. This just came out in 2017, so it's relatively recent. It's a little complicated in that the risk categories don't just go low, medium, and high, but they go low, moderate, high, very high, and even extreme. But I just wanted to give you the sense that in the extreme risk patients, people who have had progressive or premature atherosclerotic cardiovascular disease and have multiple risk factors, let's say a person in their 40s who's had open heart surgery, multiple stents, et cetera, has even had a stroke, the idea is to drive the LDL down very, very low to less than 55 milligrams per deciliter. And you can see that very high risk participants or patients, you want to go less than 70, and then high risk and moderate risk less than 100. And if people are essentially healthy, we probably want to make sure we drive them to a value less than 130, though it doesn't have to be pharmacologic in terms of the medications that we use. It can be dietary and lifestyle changes. So the old question that always comes up and surfaces, can your LDL cholesterol be too low? This seems to be a question, is there such thing as too much of a good thing? And I wanted to show you a slide adapted from James O'Keefe at Kansas area, and he did a meta-analysis of the statin trials. And what you can see on the y-axis vertically is heart disease events, so heart attack, stroke. And on the x-axis, you see the LDL cholesterol ranging from very high at 210 down to extremely low at 30. And what you see is a linear relationship that the lower you go with your LDL cholesterol, there still appears to be a significant benefit in terms of reducing the ischemic complications of atherosclerotic heart disease. So this seems to say can't be too rich, can't be too good looking, and can't have too low of an LDL cholesterol, at least if you're a relatively high-risk patient. And I think we'll talk even now, recently the Improve It trial looked at adding ezetimibe, another drug, to a simvastatin, and getting the cholesterol down to 52 was better than having the LDL 66. Let's switch gears for a moment, and I'm not sure if any of you guys have heard of this class of medicines. It's called the PCSK9 inhibitors. They're basically sort of biological drugs that you inject subcutaneously that block the enzyme which degrades the LDL receptor on the liver. As you may know, cholesterol circulates in the bloodstream, but when it hits the liver, these little receptors, which look like tiny hooks that are blue, will capture the LDL and bring it within the cell, leading to endocytosis, recycling, and breakdown, and that will lower your cholesterol. And so if you block the enzyme that you can see here with the X that breaks down these receptors, you can imagine you'll have more receptors, so you can clean out your bloodstream better and have a lower cholesterol. So a trial design that I wanted to share with you briefly was published recently in the New England Journal of Medicine, the results, but this was a study of 27,000 high-risk patients with cardiovascular disease. They were already on high or moderate intensity statin with or without ezetimibe, and they had an LDL cholesterol that just had to be greater than 70, and they were randomized to evolocumab subcutaneously, 140 milligrams every 2 weeks. This is a PCSK9 inhibitor, or a placebo injection of saline. And what you can see is, compared with placebo on the top in blue, there was about a 60% or a 59% reduction in your LDL cholesterol, as low as around 30 milligrams per deciliter. So very, very low, and the results happening as quickly as 12 weeks and persisting at 168 weeks. You can see on the x-axis, again, the LDL cholesterol is on the y or the vertical axis. If you look at the 5-point major adverse cardiac event, or MACE, so that's a combination of heart attack, stroke, and cardiovascular death, as well as revascularization, you can see a substantial separation of the curves where the evolocumab, which is depicted in red, has a lower cumulative incidence of the bad outcome relative to the placebo. And you can again see that's relatively about a 15% reduction with a hazard ratio of 0.85. So it was successful in that regard. And I think this really says to us that really LDL cholesterol lower is better, because if you look at patients divided by their quartile of what their baseline LDL was and how they were treated, you can see that people that are driven down on the x-axis from 120 down to even as low as 20 milligrams per deciliter seem to do better. And so this is clearly an example of how you really probably don't have a clear asymptote, and that for high-risk folks, getting their cholesterol lower is really beneficial for them in the long term. So again, just to reiterate, the American Association of Clinical Endocrinologists, if you have somewhat of extreme risk in your clinic, or that you're working with as a community health worker that is out there that has had multiple heart attacks and has been receiving stents or open heart bypass surgery, or has had peripheral vascular disease and has been going in and out of the hospital, one of the things we've got to do is we've got to focus on getting their cholesterol down low. Probably less than 55, or based on the studies I just showed you, maybe even lower than 40 milligrams per deciliter. So I think clearly the greater the treatment risk in terms of events, the better the treatment benefit. So I'm going to switch gears for just a moment. We talked about cholesterol, and we talked about the population approach as well as treating to lower targets. And now we're going to talk about the new guidelines in 2017 from the American Heart Association and the American College of Cardiology for treating, preventing, and detecting blood pressure. So the old terminology, I don't know if you guys remember this, 120 over 80 is sort of the normal blood pressure, and we used to call pre-hypertension if you were 120 to 139 and your bottom number or your diastolic was 80 to 89. They've sort of changed the categories, and so now if you look here in terms of the first category is normal, and that stayed the same, less than 120, so 119, and less than 80, so 79. That would be a normal blood pressure. And then now they talk about elevated blood pressure, that 120 to 129 and less than 80 are actually considered elevated blood pressure, but they're not calling it high blood pressure or hypertension, just saying that, hey, it's elevated, and that's something we need to watch. Hypertension has now been shifted. It used to be 140 over 90, as you remember, and now it's 130 to 139 for the top number and 80 to 89. So really people that used to be considered pre-hypertension in many regards are now considered stage 1 hypertension. So that's a big paradigm shift for us, and I think as primary care physicians, nurses, medical assistants who are taking blood pressure, people out in the community such as patient navigators or community health workers need to be aware of what these numbers represent. High blood pressure stage 2, as we mentioned before, that case of a guy who had a blood pressure of 150 who went on a DASH diet, that's actually anything over 140, and that used to be 160. So stage 2 has now been lowered as well, so 140 over 90 or more. And then now I think they call this hypertensive crisis, higher than 180 and higher than 120 on the bottom number. I think Nick and I would agree that using the term crisis is not exactly something we want to do, particularly if we're screening people out in the community or in a remote rural health center and the patient feels perfectly fine. So I would say this is a hypertensive urgency or hypertensive or severe hypertension that needs to be dealt with, but the idea of crisis I think probably is not a wise decision, and that really it just means that we need to manage that person quickly, probably getting them into the physician's office within a week or certainly within a few days if possible. So if we have these new guidelines that have made blood pressure cut points much lower, this is going to really expand the prevalence. So let's take a look at that. If you look at the prevalence of hypertension based on the two systolic blood pressure and diastolic blood pressure thresholds, what you can see on the sort of second column from the left, that the overall age-adjusted prevalence of hypertension will be 48% of men and 43% of women actually would have hypertension. So nearly half of the U.S. population would actually have considered high blood pressure. Contrast that to before on the right column where we used to use 140 over 90, and in that case, only about a third of the U.S. population has high blood pressure. So the idea is that this is really going to expand the number of people that we're going to be focusing on for preventative therapies and even, as we'll talk about, ultimately for drugs. I will mention that there are some issues, certainly as you get older, the rules of 10% apply, that 10% of 10-year-olds might have high blood pressure, 20% of 20-year-olds, and 70 or 80% of 80-year-olds. So as you get older, blood pressure prevalence certainly increases, and that it's a little bit more of an issue for non-Hispanic Black patients, and to a lower degree, you can see that it's a little bit higher with non-Hispanic whites, and that Asians and Hispanics themselves have somewhat lower risk of high blood pressure. So again, looking at this pictorially from an editorial by George Bacris in the New England Journal, as defined by JNC7, we had about 72.2 million Americans that had hypertension. Say our population is 320 million. And now hypertension defined by 130/80 has gone to 103 million. So really a third of the population appears to have hypertension. The good news, though, is that additional pharmacologic therapy for many of these people will only be needed in an additional 4 million adults, so that some of this can be handled with a more aggressive lifestyle and ancillary measures. So from a practical perspective, you're out there, you're in a clinic, you're out there in a public place, you're doing screenings, you're evaluating blood pressure. Some of the key steps for blood pressure measurement are really to properly prepare the patient and use techniques. What you want to do is document 2 readings at each visit, then average the 2 readings, sometimes putting some space between that, and you want to provide the blood pressure readings back to the patient so that they're aware of it and they can write it down and keep it for their records. So the rule of 2s is that you want 2 values per visit and 2 separate visits, and at that point you can actually diagnose hypertension. It's not to say that if someone comes in for 1 visit and their blood pressure is 200/100, you can't really diagnose them as hypertension, but technically speaking, the idea is that this will eliminate the spurious readings that could be associated with acute pain, acute intoxication, drug use, etc. So again, to remind you, if the blood pressure is over 120, that's elevated. If it's over 130, that's stage 1 hypertension. And if it's over 140, that's considered hypertension stage 2. So at this point, I'll pause for a moment and see if there's any questions that people have. Feel free to speak up if you have any questions about the new blood pressure guidelines. So want to just mention that 24-hour ambulatory blood pressure monitoring is a good way to do things, and you can see that clearly we use different cut points in terms of diagnosing hypertension, whether it's in the clinic, whether it's daytime, or whether it's 24-hour. And that's, again, an advantage of ambulatory blood pressure monitoring because it tends to be lower than what you would see on a single visit at the clinic. There's white coat hypertension, which you guys are probably familiar with. You go in to see the doctor, and it really seems to be a relatively high value. Yet at home, it tends to be lower. And the idea is that if their daytime ambulatory blood pressure is fine, despite the white coat hypertension, then you don't have to necessarily start medication. There's also a phenomenon called mask hypertension, where you have an office blood pressure that's essentially normal, but on ambulatory blood pressure monitoring, it's high. And in that instance, what you want to do is go ahead and start lifestyle modifications, annually follow them, and consider starting them on antihypertensive drugs. Potential factors that are associated with mass hypertension: in about 1 in 7 patients will have a normal office blood pressure, but will still be elevated if they check their blood pressure at City Market or King Soopers. It's coincidentally low blood pressure in the office, and it may not reflect adherence. So this is just a phenomena that we don't understand. But again, both mass hypertension and white coat hypertension always have a higher risk of mortality long-term than people that are normotensive. So it is something that we need to be aware of in our populations that we're taking care of with our public health program.
Dr.
So what
Mori
point do we
Krantz?
treat? Yeah.
Hi, this is Ronnie. Going back to the other slide where you talked about the phenomena of patients probably not taking their meds prior to the visit. I work in a primary healthcare setting, and one of the things that we have identified, and we try to kind of create a culture when it comes to our patient visits, is reminding our patients to always take their necessary meds before coming to an appointment. I think there's a lot of our patients misunderstand that if they come in for fasting blood work, that means do not take anything, don't even drink water. And so we've worked really hard to try to educate our population that when they come in for a visit, we want them to not only bring their meds, but also take their doses as needed, even if they are getting fasting blood work. And I think it's just something that just a lot of our patients just don't seem, they just make these assumptions. And so we try to just really try to educate the patients, because to this day, after doing this for some years now, there's always a couple of patients that still to this day just assume that coming in for a fasting blood work means not taking anything at all before their appointment.
That's a great point, and I would encourage everyone to adopt that because I think this idea of fasting is really related to food, but not drinking and not pills. And I think that gives us a much clearer picture of where these patients are at. And so I think that I applaud you, and I would recommend everyone kind of have that as part of their tickler system. So when people call them to remind them to come in for their appointment, make sure that's recommended as well. So that's great. So again, just to remind people that if you have comorbidities, diabetes, kidney disease, heart failure, anytime your blood pressure is over 130/80, we're going to recommend you essentially treat. If people have no clinical cardiovascular disease, that's the general column 2, and atherosclerotic risk less than 10%, we're not going to treat until 140/90. So the one thing I will remind you is that if people are high risk, we pull the threshold and the trigger on medicines at 130/80. But if they're a primary prevention patient that's at low CV risk, we don't start using medicines until it's 140/90. So I just want to make sure that point is hammered home. I think with monotherapy is typically what we start 1 pill, but if you're more than 20/10 above target, we always recommend starting with 2 pills. And in diabetes, again, the goal is 130/80 and preference for ACE inhibitors or angiotensin receptor blockers, particularly if they have kidney disease or proteinuria. I'm not going to go through this long clinician sequential flow chart, but basically it's a lot of interaction, checking their risk, and tailoring therapy with a team-based approach to the patient in particular. I'll start with a case. You can see a corneal arcus senilis in your patient, and you can see that the little white line where the blue arrow is pointing. Is this associated with familial hypercholesterolemia, diabetes, or high triglycerides? Any takers? Any physicians on the phone? Nurse practitioners? Physician assistant? Okay, that's high cholesterol. That's the statin-eligible group called familial hypercholesterolemia, or those with an LDL greater than 189 or greater than or equal to 190. If the patient is greater than 190, what intensity statin should you start with? So this is someone who has a genetic cholesterol condition. Let's say they're relatively young. What would you use for the cholesterol of 190 or more for LDL, the bad cholesterol? And the answer again, the higher the cholesterol, the more intense the statin. So you're going to want to use atorvastatin 80 or Crestor, perhaps 40 milligrams, and that's called rosuvastatin. So here's a 70-year-old male. He's a smoker. He got a stent to his coronary artery a month ago. He feels fine. He's on proper medicines, and he's on high dose of the most potent statin. Blood pressure is on the high side. Triglycerides are elevated, and his LDL is 71. And your choices are, do you increase the statin dose to 80, add Zetia, do nothing because he's already on a statin, do you add amlodipine 2.5 to get his blood pressure lower than the threshold of 130/80, or do you do both 2 and 4, adding the Zetia and going ahead and treating his blood pressure a bit more? Well, based on what we talked about, the blood pressure goal will be less than 130/80, so that's reasonable to start amlodipine. And then certainly his LDL is 71. He's had a recent acute coronary syndrome, and he's still above that very high target of 70. So I think getting him down lower would be good. And I think both 2 and 4 are reasonable. Why should we consider Zetia? This was the Improve It trial where the average LDL achieved was 53 by adding Zetia to a statin, and that did reduce the risk of recurrent myocardial infarction. So this supports a target LDL in people with coronary artery disease and recent heart attack of less than 70 or less than 55 if we use the American Clinical Endocrinology Guideline. All right, a 60-year-old man who's had high cholesterol his whole life, LDL values without drugs of 300, total cholesterol of 500. He's had an open heart surgery and has had multiple stents. Blood pressure is normal. He's on a series of medicines, including maximum dose statin. What should you do next? Do you increase the statin further, add Zetia, do nothing because he's already on statin, or do you add evolocumab 140 milligrams, or do you think that both 1 and 2 are reasonable? Again, his current LDL is at 119, so this is a treat to target approach question. And the winner would be to add the evolocumab, the new injection, the PCSK9 inhibitor, to get the LDL below 55. You're going to need an additional 50% reduction. So this is what we call an extreme risk patient who's had so many cardiac procedures that we're just trying to keep them from having another one. How about a 45-year-old female with no heart disease history, and she's coming in with an LDL of 191. She feels fine. Her 10-year risk is very low at 1%. Should she receive a statin? Come on, I know some of you guys in the audience are going to talk. Come on, don't be shy. Who says yes? Who says no?
I say no.
Okay. What about you, Nick?
I'd say yes.
Nick says yes. Chris,
yeah.
What do you think?
Not her age. Her age.
Yeah, this is a tough one, but again, this is a patient who, although they're very young and their risk long-term is very low, they have that statin-eligible population where they have familial hypercholesterolemia, where they have very high cholesterol baseline, and their lifetime risk of developing heart disease is quite high, probably greater than 60% chance that she will have a heart attack within the next 30 years. So just because she's fine for 10 years doesn't mean we shouldn't treat her. All right. Which risk factor tracks most closely with which condition? So does high blood pressure tend to lead to stroke more or heart attack more? Any thoughts?
Heart attack.
Smoking tends to, yeah, that's actually different than you think. Smoking tends to be more for heart attacks, whereas high blood pressure tends to be more for stroke. So this just reminds us that all the risk factors can contribute to any type of cardiovascular disease, but that there may be differences in the manifestation based on the risk factor. So what are some ways we can get people to take their medicines? So one of the methods we use is to come up with a reminder system, involve family and loved ones in the system, because that's where you get skin in the game, where people really care about their grandpa or their father staying alive, and cue medication consumption to daily events. So what would be an event that we all do every day?
Brushing your teeth.
I know some. Yeah. So you would basically keep the pill bottle next to your toothbrush at night, and that would be a great way to do it. We encourage once-a-day medicines, and we praise them when they succeed. So part of the community health worker interaction with our participants is to see when they make changes and to then praise them and give them positive feedback. You can also tie adherence to reasons outside of themselves, like being able to save money for their college, and use visual reminders such as pictures of their grandkids on the refrigerator or something that will really allow them to continue to stay with the program. Another question, aspirin, 45-year-old female, LDL is 191. Should she receive aspirin? I think this is the same woman who had a risk of 1.2%, 10 years. Should we put her on aspirin a day to keep the doctor away? Or? Actually, the answer is no. The treatment that this person should get is what? Cholesterol treatment, right? This is a statin patient because they have very high LDL or bad cholesterol. Good. A 49-year-old man has peripheral vascular disease and his LDL is 70. Should he receive daily aspirin? And the answer is yes. If people have had atherosclerotic disease, heart attack, stroke, peripheral artery disease, we do want to keep them on chronic thromboprophylaxis therapy. And here's the European Society guidelines from 2015. You can see low-risk people, less than 10%, don't need aspirin. Medium risk, you might consider low-dose aspirin. But if it's greater than 20%, we always recommend if they don't have a significant risk of bleeding to go ahead and use low-dose aspirin. I'll conclude today's lecture by making a few summary points. Blood pressure and lipid control are the two most important modifiable cardiovascular disease risk factors, so we really need to be well informed about them. We use aspirin in patients without contraindication that have a 10-year risk that's greater than 20%, and at times, if you need to, in people between 10 and 20. We want to be more aggressive with lowering cholesterol. Less than 130 on your LDL for low risk, less than 100 for moderate risk, and for our population, less than 70 for the high-risk people, And I think that's really important to remember. And even if you wanted to, on extreme risk patients, go less than 55. The target blood pressure now is less than 130/80, but that we always start with lifestyle changes in people that are at low risk of developing heart disease and have stage 1 hypertension. So those are the people that are 130 to 140 and 80 to 90, that we don't have to jump right to the pills immediately for those folks. And I think that concludes our discussion today. I hope it was helpful. And Nick and myself are happy to take any questions that you may have about blood pressure and cholesterol control in your communities and in your clinics.
We'll open it up to questions.
Hey, Maury, this is Cindy down in Cortez. How are you doing?
Hey, Cindy, I'm well. It's so nice to hear from you.
You had just made a comment here at the very end of your talk here saying that blood pressure was more related to heart attack and smoking was more related to stroke. Is that correct?
No, the opposite. I was saying that smoking and cholesterol are more related to heart attack, whereas high blood pressure tends to drive stroke and heart failure and kidney disease. Meaning that if you think of it as a pressure cooker, like some people will do a slow cooker to get their food to kind of heat, and the high pressure can lead the food to start to change. And so I look at high blood pressure as a pressure cooker that can, let's say your brain is the pot roast that's sitting in the pressure cooker. And that's how I remember it, that high blood pressure is like a pressure cooker for the brain and more of an issue with stroke.
Okay,
whereas
thank
the
you.
cigarette smoke tends to go into the coronary arteries.
That's a good analogy.
Yeah.
Dr. Krantz, this is Ronnie again. I just to paraphrase you said earlier that now 2 events, so 2 high blood pressure readings at 2 different events, then a person can be diagnosed with high blood pressure because it's not 3 anymore, it's 2.
Yeah, two readings, and trying to do 2 readings per visit. So if, let's say, you see them and you measure their blood pressure once, it's 150, measure it again, it's 130, you could average that to get 140. And then let's say you see them 4 or 5 days later or a week later, and you still get 140 on average, then you would say that that person has stage 2 hypertension. So the idea is it's doing more than 1 reading. And what I find often in clinic is the very first blood pressure tends to be a little bit high because they're shuffled in, they're rushed. Oh, quick, sit down, Mr. Smith. They just walked through the waiting room, and they oftentimes don't let them wait 2 or 3 minutes just to rest before they do the blood pressure. So I think that's the other point to make is that, you know, I always say that don't do the blood pressure as the very first thing you do, but just talk to the person. Let them sit down, maybe ask them questions. If you're a community health worker for the Colorado Heart Healthy Solutions Program, you may start asking the questions that are required for the OSCAR system, and then you can measure the blood pressure, potentially midway in the visit. I'm not sure if that screws things up, but that's one option. And not to say that you are required to do 2 visits in the field because, you know, we're not a physician's office and we don't diagnose per se. But again, your blood pressures will be pretty reliable and almost identical to what people would get if they were within the clinic.
Thank you.
You're welcome.
Any final questions? Okay. Hearing none, I want to thank Dr. Oh, go ahead.
Oh, sorry. This is Heather in Norwood, and I just had a question. I was wondering if you could speak more about the 24-hour blood pressure monitoring and if you actually use the 24-hour blood pressure monitoring and how you incorporate that, because we looked into getting a machine for our patients who we suspected white coat hypertension, and it ended up, I think initially the startup costs were like $5,000 and you can't get any reimbursement. So just wondering if that's a practical solution and what people are doing in that field, I guess.
Yeah, it's a great question. And, you know, it's become really popular. A lot of the better resource facilities are doing it. I think Denver Health is starting to do ambulatory blood pressure monitoring. But as you say, there's an outlay for equipment, and then you're sort of having to put together lots of data. I've been sort of a little bit of a minimalist only because I've often recommended that people keep a hand log and that they go to the City Market, King Soopers, or Safeway and measure their blood pressure periodically, let's say 2 or 3 times a day. And if people have a home blood pressure cuff, which aren't very expensive, they can measure them at home. And so I haven't done the formal, ambulatory blood pressure where you're doing, dozens and dozens and dozens of readings. But I think you can sort of come up with a plan that's similar, though, that is not as formalized. Now, certainly the ABPM, ambulatory blood pressure monitoring, is going to be better than just the method I suggested. Yet at the same time, I think we can still get a clearer picture of people's blood pressure. And I would advise that if people still have relatively high or elevated blood pressure, that because people with white coat hypertension still have a higher risk, it may be worth having a low threshold to still treat them, even if they're not quite as high as they were in clinic. And I think we showed you different numbers that we would use to treat.
Okay, thank you.
Hey, you're welcome. Good question.
Hey, Mori, this is Cindy again. What are you seeing as far as a lot of the new lifestyle changes as far as the keto diet and how it's changing people's numbers? I know myself, the people that I've been screening, it seems like that they have a higher LDL number when they go on the keto type diet.
Yeah, I've not been someone who's advocating that ketogenic diet where you're essentially robbing yourself of all carbohydrates and getting ketogenic. It seems like an unhealthy way to lose weight, and it sort of contradicts the American College of Cardiology guidelines where you're talking about lifestyle changes being more of a lifetime approach. So I'm not as enamored with that type of approach, and would rather have participants or patients consider making changes in diet and increasing exercise, but not to those extremes, because oftentimes it leads to a yo-yo effect where people lose weight acutely, but then they gain the weight back, and then, as you say, the fluxes up and down in cholesterol are themselves probably a greater risk factor for developing cardiovascular disease. So I think I actually anecdotally believe what you say is right about the LDL cholesterol might even go up with those diets, including the diets where like people would eat lots of bacon and lots of protein but have no carbs. I can't remember the name of those diets. They were popular for a while.
Well, I know Andrew likes to promote a high lean protein, but once again, your servings are still the size of the palm size of your hand. Lots of vegetables, fruits in the berry family, keeping your carbs below 100 a day.
Yeah, and that's a little different than the ketogenic, though, right? That's more of
Absolutely.
Yeah, I think that's right. And I guess one message I would leave with all of you guys is we don't want you to be physicians. We don't expect you to be pharmacists, but we do want you to be aware of the medications that we've discussed. And with the help of the Oscar system, when you do see people with uncontrolled cholesterol values, and we'll start to create prompts this summer for rollout in September, but there's going to be new prompts and new guidelines and new scripting around this that will help to reinforce what you need to do in the field. But I do think it's important that on our monthly calls and on the sort of calls like this, that we bring you guys into the fold to do it. And I'd also really want to encourage that it's critically important for you as constituents of the program to try to find a physician assistant or to try to find a physician or a nurse practitioner and get them to join this call as well, because I don't think that the shared learning is the same as if we don't have clinicians in the call itself. And so again, we don't mean to task you with too much work or too much information, but each of you is assigned and required to have a physician champion as part of the program. And so I don't know if there was any physicians on the call, but it's really important that they join us as well. Otherwise, you guys are sort of disintegrated, if you will, and not part of the link system that we think is important. So I hope that makes sense. It's an encouraging thing.
Are you going to start doing these calls on a regular basis, like, whatever the first Tuesday of the month or something like that? so that we could get our champions to be involved in them?
Yeah, I thought this was something that we had been planning for a number of months, this call, but maybe we didn't give you guys enough lead time. So if this was more of a spur-of-the-moment call that just came about, but I thought, Nick, we would have a little more lead time on it.
We had changed the date at one point.
Oh.
So yes,
my apologies. That was my fault.
So in the next fiscal year, I think we are going to maybe try to have more set up, probably quarterly webinars, as to, not have to task Mori with the presentation every month. So, but quarterly calls more than likely. And to Mori's point too, if there are any physicians on the call and you guys have any questions about the Colorado Heart Healthy Solutions program, perhaps in your community, don't hesitate to contact the program. chhs.cpcmed.org is a working CPC Community Health. Yes, this is a working email address, so please contact us if you have any questions or want to know if the program is in your community as well.
Yeah, and I think we could even do these talks sort of, again, because I learned from repetition, so hearing it over and over again I think will be good.